everybody to today's program where we are going to talk about restraint and seclusion. And Isabel, are you going to turn over so I can move the slides?
Yes, you should be able to progress the slides now.
Okay. There. Okay, I just took a little delay there. So today we're going to talk about the 50 pages of requirements in the CMS Hospital COP Manual on Restraint and Seclusion. And I will say that this program is very timely because, first of all, you're going to see where there are over 2,300 deficiencies by CMS. And second of all, we're going to talk about a proposed change that we will perhaps see this year. On slide number 3, I always give you my phone number, and if you have any questions, you can give me a call. And I'm also going to be giving you the email address that you may email questions directly to CMS. And how cool is that? I have office hours Monday through Thursday, 10 to 10 Eastern Time. So again, if you have a question, you can call me. Also, the program will go right up until the time, but I can stay on and answer questions if you have them. And this is what we call a deep dive series. And we go through a specific part and go into detail. And our hopes is that you won't get one of these. This is a bad thing to get in the mail. So we certainly don't want you to get one of these. And these are headlines that you don't want to see. Girl 16 dies during restraint in an already troubled hospital. And each of these patients were actually in the face down or prone position, which you have to be really careful because they can easily get strangled. Hospital fined $71,000 for a man's restraint death. And not only did the hospital get fined, but CMS came in and ended up turning it into a full validation survey. Here's another title: State banned the fatal restraint before recent death. So 4 patients, this was at a state psych hospital, have died as the result of a controversial prone restraint technique. And so again, these are headlines that we don't want to see. This happened about 9 months ago. And what happens is when you accept Medicare and Medicaid, you have to agree to follow these standards for all patients, even if they have insurance or no insurance. And if you are found to be out of compliance, then CMS can just turn away and take away your Medicare reimbursement, which could be the kiss of death. So this is a hospital. It's a 48-year-old patient who was strapped to a gurney, and basically he was face down, and he actually died from traumatic asphyxiation. Again, this is why we don't want to, in most cases, put them in a prone position. But anyway, what was also significant about this case was that the coroner said that the patient's death was a homicide. And so if it was a homicide, then who killed him? The 2 security guards that were employed by the hospital that put him on the gurney. And he had been admitted with a gunshot wound to his arm. And again, it was the 2 security officers that had secured him face down. And there's a message in that we had that almost exact same thing happened, except it was the local police department of a hospital in northern Ohio. And they had, they call it hogtied, which is, basically putting the patient, again, tying him down, face down. And then the patient died when they came to transfer him to the behavioral health hospital. And the hospital, of course, is responsible for that patient and should have been assessing that patient. So if you have, security or the outside, law enforcement that come and restrain a patient down, just remember to make sure that you're checking that patient and it's done in a safe manner. So this was a newspaper article. There were multiple articles about this. And CMS was going to, if they hadn't come into compliance, they were going to revoke their Medicare and Medicaid, which they did come into compliance. And this was an article that came out a few years ago about rethinking restraints. And it cited a couple of studies. This one that's now 11 years old, but it found 27,000 patients a day are restrained every year in hospitals, about 5 per hospitals, and the prevalence is 50 per 1,000 bed days. Now, patient days. Now, if you look at some of the more recent data, and sometimes I've gone in and just looked at benchmark data, it's over half of that. So we have done a much better job. Restraints increase the risk for delirium by fourfold. That is still true. And in fact, I was an adjunct nursing professor for 17 years, and I used to teach the restraint component, and I would make the students, when they would put on soft wrist restraints, the caveat was they had to remain in those for 15 minutes. And it was amazing how many of them would say, "Oh my gosh, I got so mad, I got so agitated, get me out of these." And I said, "What do you think your patients feel?" And then restraints can increase the rate of pressure ulcers, respiratory complications, and even aspiration and death. And that's one of the reasons in the last 5 years, whenever I go do a live program, I will ask the group, how many of you are using a restraint jacket? And about 95% of the hospitals have quit using those because those were the ones where we were getting to, see some of these problems. And then this was the study. This is a true study. In 2006, Health and Human Services, and CMS is under that, found that 40% of hospitals failed to report deaths, and that's why CMS changed the reporting standards, which I'm going to talk about here in just a second. And this is the article and the website if you would like to see it. And this is a study that just came out in August 2016, but there are many studies. The bottom line is that we have seen the use of restraints declining. And when I first got out of nursing school, we used to restrain everybody and their brother. And now it's just the opposite. Restraint is not the first thing we do, it's the last thing we do. And we try to be creative and do everything else other than restrain the patient. In fact, I remember one time working in the emergency department before we got some low beds, and we got these, 2-inch padded mats so that we could just, put a patient in that and lower it to the ground. And so I can remember taking the mattress off one of the carts. We had this like garage door opener that we could lock everything behind it, and then we put it down on a couple of blankets, and then we steam cleaned it again, whatever it takes. I did not want to restrain that man because he was already highly agitated. And so anyway, restraints can increase agitation, confusion, adverse psychological effects. And some hospitals have compensated the shortage of RNs with other staff. And what happens is they have found that this leads to increased restraint use, and also the quality of care suffers regarding that. So this is the article, if you would like to go read it. And they looked at almost 1 million patients. That's 869 hospitals, and also looked at data with the National Data Bank of Nursing Quality Indicators from 2006 to 2010. And they found that 1.6% of patients were restrained, and that during the 4-year period, the use of restraints had dropped 50%. Again, we're getting better at using other things other than just tying patients up, and 51% were restrained from falling. So when I first got out of nursing school, and if a patient fell, I would automatically put the call light on, and the ward clerk or the nursing assistants would bring back 2 soft wrist restraints, and we would restrain 100% of those patients. If you restrain 100% of those patients, then they'll cite you under tag 154. There's more that you have to do than just an automatic, use of that. And this was just showing you the actual numbers, that if you have a low number of RNs, the odds of using a restraint were anywhere from 11 to 18% higher. And again, if you had a low number of RNs, the odds of using a restraint to prevent a fall were actually 9 to 16% higher. And again, finding that RNs were better able to find alternatives to restraint and seclusion. And of course, sometimes we just have to do that. Now, the 50 pages of requirements that CMS has on restraint and seclusion, it is in what is known as the Hospital Condition of Participation Manual. And in the COP manual, they have section numbers or tag numbers. and the restraint ones go from tag 154 to tag 214. Now, on slide number 16, we have the email address that you can now email questions directly to CMS. And Beth Hudson and Isabel Estrada had sent me 3 questions they got in advance. And what was interesting is, like on 2 of these, I had already emailed CMS in the past and gotten it in writing. So it's quite nice to be able to get it straight from the horse's mouth. And if you look in the 50 pages of restraint standards, you'll see some of them have 2 parts and some of them have 3 parts. So the first part is what is published in the Federal Register, and when regulations are final, then CMS comes along and that's interpretive guidelines so that we as hospitals will know what it means and the surveyors will know what it means. And some of them have a survey procedure. Go look at the policy, go do this. So on the top of slide 17, and by the way, these slides were sent out in advance also. And of course, they will be available. And whoever had signed up for your program, they were sent out to that individual because we do want you to have these as a resource and reference material. And also, we were so excited about the huge turnout for this program. We had over 688 hospitals sign up for that. And then if you look on slide 17, this is the email address for CMS. I'm sorry, this is the web address where you can get the manual, and it's free. And if you just hold your browser over A right here, then that's where the manual will pop up. So if I'm talking about tag 161 and you say, you know something, I'd like to read tag 161. Again, this is free. This is how easy it is. Just go out to that link, put it in your web browser, and you can pull it up. And it will look like this. It will always take you to the most current one. We actually had an amendment in November the 17th, and then again, just actually a month ago yesterday on 12/29. And the reason for the 3 things that were reflected in those new ones, just in case you're interested, was the 13-page ligature risk about preventing inpatient suicide, and texting. You can't text orders. You may be able to text other things if it's a secure platform. And then they had a little section on hospitals that are very small, because if the surveyors come in and you don't have at least 2 inpatients, it might be a little difficult for them to assess that. And then in the future, and this is important because I'm going to tell you about a proposed change in COPs. And if you're looking to how to figure out when does it get passed, if you have 1 or 2 people in your hospital that sign up for the policy memos, then when they come out, then you'll know about that. And also, you can sign up for the Federal Register. And then you just click on whatever one that you want to see. That's also where the texting and the ligature survey memos are on there. They're all in the same place. And this is an example of what a survey memo looks like. I'm going to talk about this, but they pretty much all look alike, other than they call them the Center for Clinical Standards and Quality. They kind of have a new name for that. And whenever they issue a survey memo, they reserve to tinker with it. And when they get it into the format that they like, they will issue a transmittal, and then on that very day, they'll open up the manual. And this is the website that you can subscribe to the Federal Register. So again, have a couple of people, and when that new restraint standard comes out, that's the first place you'll see it. This is a document that Dr. Jarity and Dr. Kelly and I did that walks you through the CMS hospital restraint standards. And then this is one that I did for a group of physicians that had asked me to do it, again, just going through a Word document. So how did I know that there were 2,300 deficiencies? Well, in 2013, CMS first announced that on a quarterly basis they were going to be providing deficiency data. And that's the highest number was in patient rights, and there were over 7,000, and of those, 2,300 of those are related to restraint and seclusion. And if you go to the bottom of slide 29, this is your website if you would like to see what CMS regulation, to see how many deficiencies that hospitals are getting. And this is an Excel spreadsheet. So if you want to just look at hospitals in your state, or you just want to look at hospitals that got cited in restraint and seclusion last year, you can do that. Whenever it comes out, and the most current report is October the 4th of 2017. I spend hours and hours reviewing these, and it's kind of like a treasure trove for those of us that teach the CMS conditions of participation, because it tells us what gets people in trouble and what's hot. And of course, when we're lecturing, that's why we want to say, oh gosh, look at that. And the ones this is the most current data. So on the left-hand side is the section number or tag number, and then on the right side is the number of deficiencies. So for example, tag 168, there were 422 deficiencies. If you look on the next page, the winner is tag 175. So again, this just shows you all of the tag numbers and the number of deficiencies. And again, according to the most current report that's available, there are 2,300 deficiencies. And these standards are in Appendix A for regular hospitals, and this actually represents that about 1/2 of all of the hospitals have been cited. The critical access hospitals, they have a separate manual, by the way, and I'll talk about them in just a second. And that's why we were quite excited when we had about 688 hospitals, because there's about 4,200 acute care hospitals, and so that's quite a big percentage of the number of hospitals participating in this program. And then we need to understand the terminology. CMS says that these standards apply if the patient is violent and or self-destructive, or non-violent, non-self-destructive. Joint Commission, on the other hand, uses the word behavioral health or non-behavioral health. And the decision to use restraint and restraint and seclusion is not driven from the diagnosis or the unit, but the patient's assessment. So I could have a patient who's violent and self-destructive who's in the ED or the ICU just as well as I can on our behavioral health unit. And the Joint Commission has actually been around since 1951, long before CMS. And in 2008, the Joint Commission used to have it in the federal law that they automatically had deemed status. And they agreed, like the other 3 accreditation organizations, that they would provide all of their stuff to CMS, and they would go through the process of having CMS review them to make sure that they were consistent. And that's why they rewrote all of their Joint Commission standards back on July 1, and there's, for example, 10 of them in the provision of care. And when I used to do a lot of all-day programs, I used to do Joint Commission in the morning and then CMS in the afternoon. Well, now, if you look at the 4 accreditation organizations, they're crosswalked, so we don't really have to do that anymore. We can just say, here's CMS, and if you're accredited by the Joint Commission, by the Healthcare Facility Accreditation Program, the Center for Healthcare Improvement, or CHIQ, or DNV Healthcare, then they're kind of the other 3 are kind of a shortened version of what exactly is in CMS. So the bottom line is, if you are accredited by one of these 4 organizations, today's program will also help you regarding that. And then CMS issued a survey memo back in 2013, and mentioning that there is a complaint manual. In fact, it was updated again in 2016. But it's directions to the surveyor on if they're called to go out and investigate a complaint of, alleging violation of restraint and seclusion. And anyone can access this manual. So you should have one person who is the restraint guru, king or queen, who's important to make sure that the training gets done and any changes get done and in the policy. And then again, you might want to have that person review this because it talks about how they are going to investigate restraint and seclusion deficiencies. The other thing that was significant about this policy, about this memo, is that sometimes when CMS would come in, they would not always notify the accreditation organization, which they've agreed to do. And CMS is the one that can take away your Medicare and Medicaid, and that could be the kiss of death. The OIG is the one that can assess fines for being out of compliance. And this was what that survey memo looked like. So in the proposed changes, these are only proposed. I did email 7 different people at CMS 2 weeks ago and asked them if they had any idea when these would come out, and they said no. One person offline said we expect them to come out this year, but basically is we can't tell you if or when. These are proposed rules, and we don't give out that information, which I think is pretty bad, but it is what it is. So basically what they want to do is change the terminology licensed independent practitioner to licensed practitioner to make it clear that all physician assistants could order restraint and seclusion. And please remember that, for example, in California, they have Title 22. You can have state laws and states, and if you have a state law, you need to follow it. State laws can be more stringent, but cannot be less stringent, and you always need to remember that. So, and the rest of these points I'm going to go over. It just has to do with what a PA to make it clear in my state. And it's the CMS doesn't tell you if they're a licensed independent practitioner or dependent practitioner. Your state does. And our state medical board, who regulates the use of PAs, says that they're dependent practitioners. They can't go work in an ED by themselves. And again, CMS will only enforce what your state says. So by just changing that to licensed practitioner, that will take care of the problem. And the full name, and this is if you want to see a copy of those proposed rules, they are significant. Medicare and Medicaid programs, hospital and critical access changes to promote innovation, flexibility, and improvement in patient care, a proposed rule. So anyway, as I mentioned, we're going to talk about Appendix A. I showed you how to get a copy of the manual. Just hold your browser over the A. And critical access hospitals, if you don't know who they are, they're 25 beds or less. They have to be 35 miles from the most current hospital unless there's mountainous terrain. And in the acute care part of it, they don't have any corresponding patient rights. The only time you'll see mentioned is, in fact, I just got done doing for 90 critical access hospitals this morning, a section on their conditions of participation. So anyway, the only time you see it mentioned is in the swing bed, but you have to do something. So when I work with a lot of critical access hospitals, we will usually follow the same requirements as what we're talking about today, except for the reporting requirements to the regional office, which I'm going to talk about. So again, this is the email or web address, and you just click on A, and up will pop the manual. So if you want to look at any of the tag numbers, and if you've never seen what a page looks like, this is what it looks like. Now, and whenever I would write policies, I would always say this is written to comply with, tag number 154 or whatever, or, PCO 10101 EP, 12 or whatever. And if you have a question, you always want to say, remember I gave you the email that you can ask CMS directly. I have a question about tag number A154. You don't have to say -O, but you do need to say the letter A so they know that you're talking about the acute care manual. They have home health manuals and long-term care manuals and critical access hospital manuals. And then under each tag number, it will always tell you the date that section was last amended. And that's extremely important because if I've written policies and I wrote all of our restraint policies, and you're going in and you're reviewing the policy to see if there needs to be any update, and I have a tag number listed, you can go back and say, oh, well, this tag hasn't been amended in 10 years. I don't need to worry about, this policy is probably up to date. So the first part was what was in the Federal Register, and when the regulations are final, they come out with the interpretive guidelines, so we as hospitals will know what it means. And some of them have a survey procedure. And so as I mentioned before, if you're in a system with a critical access hospital, you do need to be aware of that, although like I said, we usually implement most of the same sections. And what happens is, and then this is what the existing one was, and then I'll show you the one major change that was made. So first, CMS said that you have to report not to the State Department of Health or your state agency, but to the regional office. And they take 4 or 5 states, and we have 10 regional offices in the United States. So you would have to report to the regional office if a patient died in a restraint within 24 hours, or in a restraint or within 24 hours, or if they died and the restraint caused the injury within 7 days. So the change that they made was just the fact that if they die in 1 or 2 soft wrist restraints and the restraints did not cause the injury, then you don't have to report that. And we'll put it this way, you don't have to fill out that official OMB. If the patient dies and they only had 1 or 2 soft restraints, what you would do is you would do an internal log, and in the medical record you would document that the CMS internal restraint log was completed as required. So that's what this is talking about. And that form that you had to fill out with CMS is an official form, and again, you would send that to the regional office. And the survey memo that I just showed you, we have 10 regional offices, and what CMS wanted was the regional offices to let the hospitals in their region know about, how to, so I fill out the form. Would you like me to fax it to you? Would you like me to email? Do you want me to send it to you? And then, leave a voicemail message, what it is that you want me to do. And this is the official form, and then this is the web address where you get the form. And you have to basically print it out and then type it or write it in, unless your HR department or, your IS department can make it a form that you can do that, which is really not that hard to do. Anyway, the patient's name, hospital, all that kind of stuff. And then here you can see where you would click the type of restraint. So a side rail, and we'll talk about when a side rail is and is not a restraint. If the side rail is not a restraint, then you don't have to fill this out. So if I can lower it and get out what I want, you've not restrained me. So if somebody has 2-point soft wrist restraints or 2-point hard restraints, notice it doesn't say leather restraints, because the real leather, you couldn't really clean it. 4-point soft restraints or 4-point hard restraints, forced medication. So if this patient is just throwing furniture all around and acting out, and I get an order for some medication, I also have to get an order to do a hold if that patient's not going to hold still. And then therapeutic hold. So this child is acting out. It used to be where we could do a therapeutic hold for 30 minutes on a minor and then didn't constitute restraints. That's no longer true. And takedowns, and you want to make sure that anyone who does a takedown is, we wouldn't let anyone go into a behavioral health unit unless they'd had, and CMS mentions them by name, CPI. It was an 8-hour CPI training course. There are actually other companies that do that. But if we were going to do a takedown, only people who could go in the room that were allowed to do that. And later on, CMS says you want to make sure that your security officers train, and they recommend 8-hour training. And then enclosure beds. So if they can't unzip it and get out and go to the bathroom when they want, it's considered to be a restraint. Vest restraints, again, most hospitals don't use that. Elbow immobilizers, and if they have 2 on and they can't remove them, they consider those a restraint. Now, why 13 is under here, I have no idea, because we're going to talk about this, but law enforcement restraints such as shackles and handcuffs are not considered to be restraints for purposes of CMS. And as I mentioned, there's 50 pages of standards. And again, we just talked about the reporting, which we'll talk about it again at the end. So again, they start at tag 154. And patients have a right to be free from unnecessary restraint and seclusion. Sometimes I'll go and work with hospitals and it says they have a right to be free from restraint and seclusion. And I'll say, well, do you have anybody in restraints? And they'll say, oh, yeah, we've got, 5 people. Well, you want to say unnecessary. And they're only going to be used when necessary and not as coercion, discipline, convenience, or retaliation. So I've done a lot of programs with CMS surveyors, and I was doing one time in Maryland, and Renee, our surveyor, said, "Oh, I just cited a hospital last week. The patient spit on the physician, and that's really rude. That just that's not a good thing to do. It's not respectful." But the physician was so outraged that he put the patient in restraint and seclusion for 2 days, and they thought that was retaliation. And again, when they're no longer necessary, we need to discontinue those. And again, these apply everywhere in the hospital. So again, if a patient is violent and or self-destructive, then again, we're going to follow those particular rules. And you should add it to your patient rights statements to say that patients have a right to be free from unnecessary restraint and seclusion. And we always want to make sure we give a copy to those patients, and we always want to make sure that they sign that, yes, I received a copy of my patient rights. And as I mentioned, if the patient falls, and 100% of the time you routinely just put a soft wrist restraint on, you can be cited. Now, besides having a law degree and an education degree, I have 3 nursing degrees. And whenever I went back for another degree, I used to go to the psych hospital in town, and I would spend, a semester there. And this was kind of smart because it was a big behavioral health hospital. But instead of taking all the patients, we call it pink slipping if we're going to make them an involuntary admission because they're endangered themselves or others, instead of taking all of these people down to the courthouse, the probate court, we had 2 probate courts in the basement. And so I saw this advertised, and it said, it's really a nice way to transport patients to court if they're, combative or self-destructive. And of course, what's nice about this, if they're not kicking, then you don't have to restrain the legs, or, if they've had a stroke and they're not going to swing at you with their right hand, you can undo that one or whatever. But the reason why I like it is you can also make sure that they're breathing, and you can kind of keep an eye on them. And then rule number 2 is previously CMS didn't have anything like Joint Commission did about leadership responsibility. And leadership is responsible to make sure that we're creating a culture that supports the right to be free from unnecessary restraint and seclusion. So, for example, the CNO makes sure that all of the staff are following the rules, or our director of behavioral health would make sure that all the staff are following the rules and monitoring them and documenting, and all 50 pages of requirements. And then there's different types of audit tools that hospitals use. Now, previously, CMS did not recognize or allow the use of protocols like the Joint Commission. And it's not that they banned them, but it really doesn't really help us, because previously, if the patient was intubated and we had an intubation policy, then, initially you don't need to put on soft wrist restraints because they're so sedated. Maybe they're on a propofol or Deprivan drip that they're not pulling anything off. It's only when we want to lighten up sedation and they don't quite meet the extubation requirement. And so then if they start to pull at it, then we'll run over and we'll put on 2 soft wrist restraints. But the problem is that we still have to call the provider or the physician and get an order. So it really did not help us, because you still need to go through the process. And as I mentioned, and this is kind of what I did. So when I was at a hospital one time, we had a separate behavioral health unit, and many states will have specific requirements for that behavioral health unit. So what I did was I wrote one policy, but it had 3 sections. It could have been 3 separate policies, but I just said, Part 1, this applies if you're in the behavioral health unit, because Ohio has specific regulations for behavioral health. And then part 2, this policy applies if a patient is violent and or self-destructive, and in parentheses, I had behavioral health. And then outside the behavioral health unit. And then the third one, this one applies if the patient is not violent, not self-destructive, again, outside the behavioral health unit. So that's how I organized my 3 policies so that the staff would understand. And by the way, if you read these 50 pages of standards, they're not written in a very easy to understand format. And in fact, they're kind of disorganized if you read them. So when we decided to do education on these, I took a friend who's also a nurse attorney, a friend who is a very experienced healthcare lawyer, and we read these about 3 times, and we went into a room and we said, how can we make this a little easier, for our hospital staff and understanding? I mean, 50 pages of restraint standard, that's kind of a lot. And so what we did was we figured out there were 21 rules. And if you knew those 21 rules, then you would know what it is that you're supposed to do. And it's really important to understand the definition of a restraint. So a restraint is, again, if you hold somebody down, any physical or mechanical device, any equipment that immobilizes their arms, their legs, their body, and their head. There are things like belts and restraint jackets and cuffs and ties. And as I mentioned, most hospitals no longer use restraint vests. Manually holding down a patient, if they're violent and self-destructive, is considered to be a restraint, and there's no longer an exception for children. And somebody asked me if I would address this question. And of course, you want to put that in. We're going to talk about the definition and why you want to have that in your policy. But this was a case in the emergency department where this patient went ballistic. And so for the safety of the patient and the staff, they did put the patient in 2 soft wrist restraints. Well, the ED doctor was tied up, and by the time the ED doctor got in there, the patient had settled down and they were no longer necessary. You still need to write the order. You have an emergency doctrine. You have to you have to write the order, and then the doctor can write the order to DC it. And then the documentation would describe what the patient was like when the patient came in. And then again, when the physician went in, the area had, the behavior had terminated. And we'll talk about that. So when the behavior no longer is in existence, then we want to take them off. But you do still need to have that original order. And then CMS is more stringent about a drug and when a drug is used to restraint. So basically, a drug, when a drug can be used, can be considered to be a restraint if it's something that is used to manage a behavior or restrictive freedom of movement that is not a standard treatment or a standard dose. So in other words, if somebody is putting a patient on a medicine and they're giving them 2 or 3 times the dose, that could be considered to be a restraint. If you use something that is off-label, that could be used to consider to be a restraint. Now, say for an example that the patient is in alcohol withdrawal symptoms and we give them Ativan. That is an example that is not a restraint. Of course, we have all the new terminology with substance use disorder and maintenance therapy. But anyway, and then these 4 points should be in your policy to help your staff understand when a medication is not a restraint. So again, if I look up the package insert, it will say Ativan is used for alcohol withdrawal. It's a national practice guideline. It's used to treat a specific symptom and enables the patient to get up and move around. In fact, I was so impressed the first time I ever gave Ativan when I was a new nurse. It was a really cold day, it was like 20 degrees out, and this patient had come home intoxicated and had a couch on his front porch, and he just was sleeping on the couch, and the neighbor saw it and was afraid of hypothermia, and he was having trouble arousing him because he was intoxicated. And so he called the squad and he brought the squad in, and luckily the patient hadn't been out there very long because he yet was not hypothermic at this point in time. But anyway, he was, in alcohol withdrawal. And so, he was just, hours later was just, just like crawling the walls. And we gave him a dose, and I went back, and there he was sitting in a chair, got him something to eat, and what a difference. So again, that is part of a standardized treatment. And then seclusion is, it's not being on a locked unit, but it's an involuntary confinement of a patient. So if you lock them in the room, or if you post a security guard who says, ma'am, you're not leaving, that is seclusion. You can only use seclusion to manage someone that is violent and self-destructive, again, to prevent injury to the patient or the staff. And if the patient is acting out and I say, okay, you go down to the lounge and you sit there and you take a timeout, that's not seclusion. I mean, they might come out of the lounge. It's not locked or anything. I might yell at them, but that they could come out. So again, that's not the definition of seclusion. And then there's a very old resource that CMS continues to mention, and it was published by a number of organizations. It's available on all their websites, called Learning from Each Other. And basically, it was tools on how to reduce restraint and seclusion in behavioral health areas. And again, if they're violent and again, if they're in seclusion, then we're going to talk about all the rules that apply. Time rules apply. So if this is an adult, every 4 hours, I have to get an order up until 24 hours. And I had this question asked in advance, and I said I would answer it. But the 1 hour face-to-face is only done on patients that are violent and self-destructive. So this patient say the patient was on a unit, and at noontime this patient went berserk, and we have to have someone that's trained to go in and do the face-to-face within 1 hour. And normally what we do is, and I'll talk about that later and what training you need to do the 1 hour face-to-face, but normally we will let that person come in, do the 1 hour face-to-face, and I've done many of these in my day. And then we have that person call and get the order so that we don't have to bug the physician twice. And then on slide 68, remember I talked about the form and how 13, and I said I'm not quite sure why it's on there, because forensic restraints such as handcuffs and shackles or other restrictive devices do not constitute restraint according to the 4 accreditation organizations and the Joint Commission. Now, having said that, even though I had a full-time risk and legal job, I used to work 2 or 3 shifts in the last hospital I'd worked at for 20 years. And we had a contract with a couple of the prisons, so we used to see prisoners. And so whenever they came in with handcuffs or shackles on, I would pull out my restraint sheet and say, restraint. This is to monitor forensic restraints, which don't constitute restraints for purposes of CMS, and we were Joint Commission accredited. And but I would use that to monitor them for safety reasons, to make sure they weren't too tight or whatever. And then you should have in your policy that restraints do not include things like orthopedic devices. So they have a cast on, they have a double Schantz dressing, a surgical dressing, so they have a wound, a thick burn dressing on their right leg, protective helmets, they've had surgery. And then they've made an exception that if you have a patient that has a seizure history, and we have the seizure precautions, ours were kind of green with Velcro, and you had to have all 4 side rails up for those to work, and those are an exception under 161. And then this is an important one that sometimes hospitals don't know about, but those special air mattresses, the ones that go up and down and sideways to prevent pressure ulcers, you can put up all 4 side rails, and that's not considered to be a restraint under tag 161. And when CMS has 14 HACs, hospital acquired conditions, in which there's no reimbursement if they occur, then a lot of hospitals, for example, in all of our units, we always had the air mat, the special air beds, because we didn't want them to get a decubitus or a pressure ulcer. And then if you, it doesn't include, now they've made an exception for medical reasons. So if this is a 2-year-old and they need to have an LP, we can hold that child, or that child has the flu and we think they're getting septic, we can hold them down to start an IV or to give, antivirals or whatever we're going to give. Now, as far as protecting patients that fall out of bed. They've always made an exception for those narrow carts or gurneys. We use them in the emergency department. We use them in transport. We use them in PACU. They are so small that if you don't put up both side rails, they'll fall out, and that's always been an exception. And then on slide number 70, if you have an IV and you have an IV board in, that's not a restraint unless you tie it down. Postural supports. So if this patient goes to surgery today for knee surgery and they have the knee out, that's a postural support. That's not a restraint. Or if they go to radiology and they have their knee in the MRI machine, that is not a restraint. That's a postural support. So again, if it's for medical reasons, you can hold the child down to give them a shot, the antibiotic, whatever. If the patient comes in from the OR into the PACU and they are still intubated, that is considered to be a continuation of surgery. And most MITs are considered to be restraints. But under tag 161, for example, mitts that look like boxing gloves, they are considered to be a restraint. Now, if you can bend your forefingers to touch your thumb, then it may not be a restraint unless, again, the manufacturer says that it's a restraint. But of course, if you can bend your forefingers to touch your thumb, you can still pull out the NG tube, the IV, and the Foley. You can adequately do that. So my question is this a restraint? Well, the bottom line is we don't have enough information, and this is why documentation is so important. If this man can reach down and unvelcro this and go back to bed when he wants, it's not a restraint. If he has Lou Gehrig's disease or amyotrophic lateral sclerosis and he has so much weakness that he's not able to do that, then it would constitute a restraint. So it's not the device, it's not the thing, it's what the thing does. Okay. So, for example, this is one time I had a friend visiting me, and her child had what the doctor called a schizophrenic episode, where she was hearing voices and running around and trying to grab things and stab herself. So we took her to, there's only 2 hospitals that have an adolescent inpatient unit, but we took her to the emergency department. And so my friend was actually sitting on her child when the nurse came in and said to the nurse, "Would you please shut the door, or this child will go running through your emergency department creating havoc, and you've got some pretty sick people out there. I understand that." And the nurse said, "Well, I can't do that because that would be restraint and seclusion." Wrong. She didn't ask her to lock the door. She just asked her to shut the door. And she said, "Oh, you know what we could do is I could bring a sheet in here and we could kind of wrap her up in a mummy so that she couldn't run her own." That is a restraint. So strike 2, she's already not having a very good batting average. And enclosure bed, again, if the patient can get out and exit the bed, it's not a restraint. If they can't, it does. Again, elbow immobilizers, if they have 2 of them on, then they consider that to be a restraint. Now, one time I had a patient and she said, during the night a couple of times, I've in my sleep I pulled at my subclavian line. She said, "I'm afraid I'm going to pull it out." And she says, "Could you put a soft lift restraint on my right hand?" And of course we said, "Sure, no problem." And then whenever she would get up, she would untie it. She wanted to go to the bathroom or get up and walk around. And then when she'd go back to bed, she'd say, "Hey, can you tie my right hand down?" That would not be a restraint because she can remove it. Okay. Now, say that a patient has been violent, self-destructive, or we need to give them some medication, and I say, "Mrs. Smith, I have my colleague here, Nurse Judy, and is it okay if she kind of holds you down so you don't jump?" No problem. But again, if she doesn't consent, and then I have to hold her down because she said, "You're not giving me that," and I said, "Yes, I am. The doctor said you're having that," then again, that would be when I would need an order to for the medicine and to hold her down. The same thing, side rails. If I'm in the hospital and I say to the nurse, "I'm used to sleeping in a queen size bed. Can you put up all the side rails so I don't fall out?" No problem, but let me show you how to lower the rail. So have you restrained me? Of course you're not. Or if you put me in a jerry chair and I know how to get out, you've not restrained me. So again, it's not the thing, it's what the thing does. And that's why documentation is so very important. Now, for example, say that somebody takes the patient to x-ray in a wheelchair or to ultrasound. They make an exception for that and just say, use of the seatbelt, when you're transporting a patient is not not a restraint. Now, that it says when you're transporting a patient, if you're using it in the room and you're not transporting them, then again it could be considered to be a restraint if they can't get out of it. And then again, if the patient lowers the rails, again, like I said, it's not a restraint. And you would want to document age specific. So if it's a high chair or a stroller, as long as they're age specific, not going to be a problem. Tag 154 is a tag number that it's only about one page. You should share it with all of your security. Your security should have this in training and education. CMS does not consider the use of weapons on patients by hospital staff as being safe. We've gone over and over with this many times, but basically you can't go use tasers and stun guns on your patient. Now, if you have an active shooter or you have a patient that pulls a knife and tries to shoot somebody, then that's criminal activity. And of course, if someone goes ballistic, they expect us to call the local police and have them come in. But again, if you have an active shooter or someone's breaking into the pharmacy, then that's a different story. But you do want to make sure that security are aware of the requirements. And then, and I think we've always done that. A patient is on the medical unit and has been there for a day and a half, and all of a sudden the patient goes ballistic. And you're thinking, okay, what changed? Well, if this patient's a diabetic, maybe I need to go check their blood sugar to see if they're hypoglycemic. Or one time I had a patient that came in the emergency department, and an hour later, again, had a behavior change, and I knew she had a history of renal failure. So I called the lab and I said, hey, is that BU and creatinine back? I'm trying to figure out why all of a sudden my patient is being, swinging at people and whatever. And they said, oh yeah, I was just getting ready to call, so again, she's in renal failure. Or somebody's getting into septicemia, or I just gave them a dose of, well, I was going to say Demerol or Pyridine, but we don't use that very much because it does cause some confusion. So say I gave them Dilaudid or hydromorphone, and then I go back and all of a sudden, they're acting strange. Maybe it's a drug reaction. And again, as we mentioned, the use of restraint is not considered to be a routine part of a fall prevention program. Not that we can't use it sometimes, but like I said, the automatic one where we used to, anyone that fell, we used to put them on, isn't going to cut it anymore. And you need to have the reason for the restraint. So when I was at the hospital one time, I created a one-page order form. And so maybe our physicians and our providers, maybe they didn't know all 50 pages of restraint standards, but everything they needed to be on there was on there that they could mark, the order and things like that. So one of them is the reason for restraint. And so we had things that they could mark, but we also made it clear they're attempting to harm others and property. They demonstrate lack of understanding. So, and then we had a little note that you need to document specific in the progress note, in the nursing note, what was going on. So if they're attempting to harm others or property, what were they doing? Walked into the room and patient was throwing furniture around, or patient tried to bite the nurse, or patient was kicking the nurse, or patient took out their IV, pulled out their IV, and they're with the balloon fully inflated, and that's got to not feel good. You've all seen that. So again, we want to be specific about, again, if you have check marks, make sure, don't just say they're disruptive or combative, go and say why they're combative. Be specific in your documentation. And so again, we would do certain forms. Now, when we talk about alternatives, it actually says considered or attempted. So I would, and there's a lot of things that we document that we do on that. So rule number 4, you want to use least restrictive interventions. And so tomorrow, by the way, is the full moon. They call it the super blue blood moon. And my friend, who's a psych nurse, informs me that when that happens, patients tend to have a little more confusion. I don't know. But anyway, So sundowners is when there's a full moon, patients used to get up, or at midnight get up and walk around, and CMS says, oh, was that a trouble? Was that a problem? They're not hurting anything, so maybe they worked the night shift or whatever. And then also a request from a patient or family member is not sufficient if it's not indicated. So twice I had this occur, and once the first person was a physician. So I showed her the CMS section on this, and I said it's not indicated, but what we have a lot of tools in our arsenal, and why don't you and I sit down and do a plan of care that you feel comfortable with and that we think will work? And I said, we have all of these things. Well, it turned out that the daughter said, my mom only gets confused when she's in a strange place, and for some reason it's only, after midnight. And she said, I just would like to stay overnight. And I said, we can make that happen. I can put her in a semi-private room and give you the other bed. And then these are all the other things we can do. We have low beds. They go down to about 2 or 3 inches from the ground. I have 2-inch padded mats. I have a wedgie that I can put in so she won't roll off. We have perimeter alarms that normally a lot of times some of them alarm in the rooms and some of them alarm at the nurses thing. You may be aware that especially in long-term care, those sensitive alarms that kept alarming and patients would be afraid to move, those are creating a problem. But again, if the nurse has it, or it doesn't happen that often, then that's not going to really restrain the patient's movement. But anyway, so we said these are all the things in our arsenal. These are things we can do. I can never guarantee your mom's not going to fall. And both of them were very happy with the treatment. We have sitters, so we went through the whole list of every tool we had and what we could do to make sure that you're happy with this. And so again, that's rule number 4. And I had a call from a nurse, and she said, Sue, I'm going to be listening to your call, and I was wondering if you could talk about this. She said, I used to work at a hospital for 10 years in the emergency department, and if they only needed 2-point restraints, we just put on 2-point restraints, 2 soft wrist restraints. She said, but now I've gone to this new emergency department, and it's 4-point or nothing. Is that a problem? Yeah. They're not kicking, are they? No. Is there any reason that you need to put on ankle restraints? No, not at all. They're underneath the sheets and covers, and no, they're not doing that at all. And then you have to provide training. Actually, there's 10 pages of training requirements that we'll go through and make a list and kind of check them off. So one time I was working with this hospital, and they had a lot of restraints on the medical unit, and they had a lot in the orthopedic unit. They did a lot of elderly patients, and they were doing a lot of restraints because they were getting a little confused and pulling their IV out. So there was a company that made it was kind of like a plastic thing that stuck over that, and then they make these nice kind of like gloves, but they don't have, and they're quite comfortable. The first time I used one, I actually wore it all day, and sometimes the patients like it so much they want to know if we can put one on the other arm, but they're not even considered to be restraints, and we reduced restraints by 54%. With using, and they make them to match the skin color of the patient, kind of out of sight, out of mind. But that was one way. Rule number 5 is that you need to, again, consider alternatives along with least restrictive. So what are things that you can do other than tie the patient up? Again, a sitter or a family member staying. One time I was working in the emergency department, and I had this patient, and I had put in a Foley, I put in an IV. He actually had a couple other tubes in, and I didn't want him to pull his tubes out. So he had 2 children in the waiting room, and I said, hey, do you 2 want to come back, and I'll put one of you on one side and one on the other, and you can kind of hold his hand. And I said, that way I don't have to restrain him. They said, we would prefer that. We've been wanting to get back. And so I brought him back, and I went to lunch, and when I went to lunch, somebody said, oh, you can't have 2 visitors in that room, and they chased them out and put the patient in restraint. No order. Nobody seemed to know anything about it. Nobody admitted to doing it. So again, I had tried, I've always tried to be creative, and what can I do other than tie somebody up? Sitters, again, and having a full list of alternatives in your toolkit. when my nephew was 2 years old and had an IV in the hospital, we didn't want to tie down his little arm, so somebody always stayed with him. And we had the little DVD players, and we watched a lot of video films and did a lot of distractions. Give a kid a laptop or an iPod and iPad, and they'll be occupied for hours and forget about the IV or whatever. And so these are some of the things that you can do. And when I was a junior and senior in high school, I worked at the local hospital, and sometimes I worked in the emergency department, and sometimes I worked on med-surg units. And I worked 2 to 10:30 because I went to school. And so every evening we would put a clean draw sheet in. We would always give them their HS snack so they didn't wake up hungry. We would do toileting, take them to the bathroom before we went off all of our shifts. And we were required to give them a 3-minute back rub. And it's amazing how many patients would actually sleep and not wake up in the middle of the night. We didn't have to worry about, getting confused or whatever. And there's the skin sleeves that I was mentioning earlier. So these are some of the alternatives that you can do other than just tie them up. One patient, we had to limit her caffeine because she used to drink large amounts of tea, and so that would keep her up. So we did that. So again, these are all things that you can do. Blood pressure medicine, we found that instead of giving the diuretics at 9 and 5, maybe at 9 and 1, and then they didn't get up and wake up because of the diuretic, and that worked too. So these are all examples of alternatives. And this particular one was provided to us through KeyPro about, again, some alternatives to using restraints. So again, put these in the back as kind of as a resource. And then rule number 6, we have to read with rule number 7. But licensed independent practitioners can write orders for restraint. Remember, this will be changed, at least the proposal is to change it to LPs. And CMS doesn't tell you what an LIP is, your state does. So for example, our Board of Nursing says that our nurse practitioner is an LIP. They can admit, they prescribe a licensed resident, not a medical student. You do need to specify in your policy, again, who is an LIP. And also, say for an example, we didn't use restraints very often in the emergency department. Again, we were pretty creative and had been for a number of years, but we had one patient and she just had to be restrained. And so anyway, the resident had written the order for the 2 soft wrist restraints. And so I said to the resident, did you notify the attending doctor that his patient's in restraints? And he said, yes, I did. And I said, well, would you be sure to document that? And I sure did. I documented that, Dr. Smith, the internal medical resident, verified that the attending was notified, because that's a requirement. We need to make sure the attending knows that his patient or her patient is in restraints. And as I mentioned, if they're violent and self-destructive, then the RN or PA or nurse practitioner, whoever does the face-to-face, we usually will have them do that first and then notify the attending so we don't have to bug them twice. We try to minimize the number of disruptions to our physicians. And then again, we would document that notification. And they're very adamant about you always need an order by one who's allowed to give an order, except in an emergency. You have the policy, and then you get the order. And generally, we don't allow PRN orders with the exception of 3 things. So I can't allow, say this child keeps banging their head against the wall, I can't allow them to give themselves a subdural hematoma. So when that self-mutilating behavior starts, I've got an order that I can restrain them. Or the doctor writes, when out of bed, have the patient in a jerry chair. Again, the fact that the doctor wrote that doesn't tell me whether or not that patient is restrained or not. Again, if they can get out of it, it's not. Or the doctor writes, when in bed, have all 4 side rails. Again, the fact that the physician writes that doesn't tell me if it's a restraint or not. If they can't get out of they can't lower the side rails, and their only choice is to crawl out the bottom or crawl out over the sides, then it constitutes a side rail. And then when I put that patient in bed, I would pull out my documentation sheet and then I would, document during that time. That's also why in a lot of hospitals you will see the top two side rails and one bottom side rail so that the patient can raise themselves and slide themselves out and get out of bed, and it doesn't constitute restraint. Rule number 9 is if you use restraints, you gotta have a plan of care, and you need to amend your plan of care. Now, CMS doesn't mention debriefing or de-escalation, but de-escalation is sometimes the way you talk to a person. If you don't do this, I'm going to call security and I'm going to tie you up. We have seen a couple of hospitals cited because of the way that we talk to patients that's not therapeutic and appropriate. Debriefing is where we would, and these are, debriefing and de-escalation are the standard of care for behavioral health patients, by the way, especially on behavioral health units. But debriefing was where we, at the end, say, is there anything we could have done differently to prevent this from happening in the future? And it was Joint Commission came out with it because of all of the behavioral health patients that we're seeing, especially boarded and waiting to get a bed or whatever. Rule number 10 is we need to end them when they're no longer necessary at the earliest time. And it used to be where a trial release was allowed. It's not permitted anymore. So trial release was, well, I got an order for 4 hours. It's only been an hour. I'll just see how the patient does, and if they fail the test, I can put them on. I still have 3 hours left on the time clock. That is no longer true. If we get it wrong, then we have to start all over again and get an order and go through the process. However, a temporary release is permissible because I'm going to get them up and walk them to the bathroom or the bedside commode, toileting, or range of motion where I untie them, or I'm going to untie them to help with the feed for their dinner tray. So again, you've got to have a policy. You got to end them. One of the questions that I sent to to CMS, and somebody had emailed me this and asked this question too. So in the policy, in the order that we wrote, the physician puts some criteria where then we can end them, take them off if they're no longer necessary. And so when that criteria happens, then the nurse can take them off, and then the nurse writes the DC order, and then the physician comes or the provider comes and signs off on that. And again, if it's an emergency, you put them on and you get the order, and you should have that in your policy. As we mentioned, whenever somebody, their behavior changes, we want to do an assessment to find out what's going on. It used to say that you had to continually monitor patients, and we don't have eyeballs 24/7 unless they're in restraint and seclusion, and we monitor them at intervals. CMS does not say every 2 hours for non-behavioral health or every 15 minutes for behavioral health. A lot of states will mandate that, and it's become kind of a standard of care for behavioral health patients to keep an eye on them. And a lot of hospitals have actually instilled cameras, audio and video that you can watch. But anyway, for example, and a lot Joint Commission used to say that you had to do it every 2 hours if they're nonviolent and self-destructive. Again, CMS doesn't require that. You have to specify the time period. So a friend of mine is a nurse that works in a pediatric hospital on a unit where they have cleft lip and palate, and what happens is they do it every 4 hours. And if you do pick 2 hours or 3 hours, say at approximately every 2 hour intervals or approximately 4 hour intervals or whatever you're using, because if you say 2 hours and it was 2 o'clock and then the nurse isn't in there till 4:15, you have violated your own policy. But if you say at approximately 2 hour intervals, then if I'm working a 12-hour shift, then I know I have to do 6 assessments or whatever. And again, we created an assessment sheet to document everything that we needed, because when you restrain somebody, I don't want them to get dehydrated. And anyone I had in restraints, I always put them on INO. And whenever we went in there to 2 hour assessments during the day and evening, we would offer them fluids. So would you like a drink of water? Would you like something to drink? And then we would document that. We would monitor their vital signs. Again, we would get them up and ambulate them to the bathroom or the bedside commode and do toileting. We don't want them to get a full bladder. And then we would check for circulation. We would check for skin integrity to make sure there's not abrading the skin. And again, document that we've assessed them and again, when they're no longer necessary to take them off. They want us to be very specific at documenting the behavior and interventions. So if you say they're confused, that's fine if you go on to define what that means, or they're combative. In fact, they were attempting to strike the nurse with a fist, or the patient kicked the nurse, or they attempted to bite the nurse, or whatever it is. And again, we want to be very specific about the symptoms and conditions that warranted the utilization of the restraint. So and somebody asked me this question. This is another one they called in. If we have 4-point restraints and we want to reduce it to 2-point restraints because they're not kicking, do we need a new order for that? Unfortunately, yes, you do. So elbow immobilizers, again, mitts, 2 soft wrist restraints. Again, we don't usually use vests. Now, papoose board, after they made changes a few years back, if I have a child and I'm going to suture them, then a papoose board would not be a restraint. If you have a child who's acting out and you put them on a papoose board, then that would be a restraint. So, which I've never seen people do. The only time we use papoose boards is, again, when we're suturing children in the emergency department. And then, so again, you want to have sheets that, again, comply with all the requirements. Now, this is an example of a bad documentation. So I was at a hospital and they wanted me to come in one day and look through charts and get actual examples, because the next day we were doing an all-day program on documentation. So here they were doing it at 2-hour intervals. They didn't have the time of the actual one. And so I came in at 7:30 in the morning, and this is the first chart I picked up. And so it had circulation checks. It had them all checked. And I said, what were you checking? Were you checking to see if their fingers were pink and warm? Were you checking pedal pulses, capillary refill, elimination, and bathroom? They had all these marked. And I said, did you really take this patient every 2 hours to the bathroom? And if so, did you document no results, BM times 1, voided 240 cc's, skin condition, food and fluid? They had every one of them marked. And I said, did you really wake this patient up every 2 hours and offer them a trial release? Again, no such thing. So not a good documentation tool. And you want to be able to document the process. So again, have all of what we need on an order sheet on one place. You have to do QAPI to make sure you're not using them more on weekends or evenings or with agency staff. When I did QAPI in a number of departments that I visited, I had one nurse and she seemed to be the only one who used them. So again, we had to do an intervention. Rule number 13 is that you need to use them as directed. So, for example, when we used to use vest restraints, half the time I'd see them crossed in the front and then tied underneath the bed. The other half the time I'd see them crossed in the back. If you read the manufacturer's instructions, they crossed in the front. Or the slip knot for a for a soft wrist restraint. And we'll talk about the difference between education and competency, but I want to make sure my staff are competent. So I may do the training for them, and we'll talk about how you need to have training on an ongoing basis. With CMS says it to me is every year. David Ettinger told me that. But the bottom line is, I'm going to hand them one and I'm going to say, put on the soft wrist restraint, and I'll make sure they do it. That's their competence. So training is, and competency is above that. Rule number 14 was the lightning rod for comments and activity. It used to be that only if the patient went violent and self-destructive, only the physician could do the 1 hour face-to-face. And how stupid was that? Do I want a surgeon coming in at 4 in the morning to write an order and see a patient when they've got surgeries all day? I don't think so. It doesn't sound to be very safe to me. So again, if they're violent and self-destructive, that's the only time that you have to do a 1 hour face-to-face. It could be by a trained RN, it could be a PA, it could be a nurse, it could be a physician. I trained all the nursing supervisors. I used to train all of our behavioral health nurses, and we trained nurses on each unit that could do the 1 hour face-to-face, especially in places like the emergency department. But also having trained all the nursing supervisors, then they could also do that. And that way I can call the physician and notify the physician that his patient is in restraints, and again, get an order for that. And CMS, and then, for example, If it's, say that patient went ballistic at noon, and by 1 I get in there, I do a face-to-face, and I get an order for 4 hours. And I can renew that order every 4 hours for adults up until 24 hours. And we'll talk more about that in just a second. Now, on slide 117 and 118, you might want to consider having a form that no matter who does the 1 hour face-to-face, this information is contained. For people who were going to do the 1 hour face-to-face, we did the program that we're doing, which is an hour and a half on what are the 50 pages of standards. We had a computerized module that would go through this form and how to fill it out. And then we did require everyone to have an 8-hour train the trainer. And like I said, CMS specifically mentioned CPI in the Federal Register, but there are other companies that are doing that. But they had, and we did a train the trainer class once a month, and they had to go through that. So you want to document their reactions. Let me just go back there. You want to document their reaction. If you go in, are they sleeping? Are they clonic tonic agitated? What's their medical and behavioral condition, which I'll talk about more in just a second? And is there a recommendation to continue or terminate the restraint? And so you want to, again, if there's an H&P on where you can do a review of the systems, again, is this a patient that was admitted for a behavioral health issue like schizophrenia, or was this someone who was admitted for sepsis? Again, what's causing it? Are they hypoxic? Are they diabetic? Is this a drug interaction? And then we're going to have a plan of care and document the plan of care. And again, we need to train the staff in slide 117 and 118 about what needs to be documented. So I mentioned if they're an adult, we could renew it every hour, every 4 hours up until 24 hours. For children, it's 2 hours, and if they're under the age of 9, it's every 1 hour. And again, this is only if they're violent and or self-destructive. Now, if they're not violent, non-self-destructive, you have to renew the order to whatever your policy is. It could say daily. It could say 48 hours. So whatever your policy is, if they are non-violent, non-self-destructive. Some hospitals felt it was confusing to have two different standards. And one hospital I went in, and they just decided to make it 24 for everyone, but they were out of compliance. And so why would you shoot yourself in the foot and have a more stricter policy when it's not necessary? You need to have a policy on restraint and seclusion, and everything that we said has to be in there. And I suggest that maybe you might want to do a gap analysis, that you take the 50 pages of standards, you go through it line by line and say, where's it in my policy? Where's it in my education? Where's it in my process? And then that will go a long way to a surveyor walking in and wanting to see, what your policy is. And then rule number 18 is staff education. Again, CMS said ongoing. I didn't really know what that means, so I asked David Eniger, the head of the CMS hospital program, and he said we expect them to have annual or yearly education. So again, you want to have one list. The section on staff education, what you need to educate, is 10 pages long. So what you want to do is have like a one-page document where you can list everything. And then you have to have, I did a checklist, and everyone who comes in contact, so for example, our RNs, LPNs, and nursing assistants apply, take them off and monitor, so they need to be trained in everything. Don't forget your ultrasound technologist too. If you send someone to ultrasound who's going to take them off and put them on their bed, or the radiology tech, if they take them on or put them off or do anything, they need to be trained in whatever it is that they're doing, whether it's putting them on, monitoring them, and providing care. And patients have a right to have them safely put in. And you have to make sure staff are trained before they actually do it. So my niece went to school with me, and when she got her BSN, she went to a program that was 9 weeks. Half the morning was in class and the other half was on the unit. You would want to move this up to the beginning so that she could take care of patients and, again, then put them on, take them off, or monitor them, because you have to be trained before you do that. And you also want to do training on what could trigger a reaction. So one time we had this patient, and she was in a room with the patient in the other bed was hard of hearing, and we noticed that every time the other patient would turn the TV up, it was really loud, this patient would go ballistic. So finally we figured out what it was, and we put her in a private room and didn't have that. So we already talked about de-escalation, except for the Joint Commission. PCO 10101, EP 4 and 24, because again, we're seeing a lot of boarding of behavioral health patients, especially in the emergency department and whatever. But de-escalation, again, it's just, again, as I said, the way you talk to someone, and even though it's not in the CMS requirements, they still feel that they can cite you. And a personal de-escalation plan, so someone says that they were once sexually assaulted, so the last thing you want to do is hold them down because that would be counterindicated. What can you do other than tie them up? Making sure that you're teaching them on least restrictive, making sure that all the ones that you use, people know how to apply those and to apply them correctly. Monitoring them, again, how often, the skin integrity, making sure they're not too tight. When they say first aid, they're not talking about taking a first aid course, but if I walk in and this patient has the soft wrist restraint wrapped around their neck, then I'm going to extricate them. If they're not breathing, I'm going to start CPR and call a code. That's what they're talking about. Or they pull their IV out and I don't want them to exsanguinate, so I'm going to stop the bleeding and put a new IV in. So again, develop some scenarios. Again, they do recommend that your security staff have like an 8-hour course, like a CPI or something similar. Because what do? Security stat to the emergency department. Now, they don't mandate how many hours of training. They do make a recommendation, 7 to 16 hours. And our behavioral health staff used to get 8 hours, but our other staff did not. But again, it's only a recommendation and not a mandate. So is this staff that's been there for 20 years and it's just reminding them every year, or all of a sudden you look around and they're all new employees? And we used to do a post-test in orientation and annual education. We did patient safety walkabouts, and they had a couple questions they would ask, and I would get all this data because every year I was a person who would determine if our program needed to be revised. I would do a literature search, and I would look at the percentage of people that were getting the questions correct during the walkabouts, safety walkabouts, to determine if we needed to do more education or training. Now, with physicians and LIPs who write orders, at a minimum, you have to make sure that they are knowledgeable about your hospital policy. So every 2 years when we credential and privilege them, I would say CMS requires you to be knowledgeable about our policy. Therefore, you need to read this and sign an attestation that you have received it and that you understand it. And then I had tons of other resources. States can be more stricter. I already talked about that. So if a state wants to make it more regulated, they can. And then we don't need to do one-to-one monitoring unless they're in restraint and seclusion. I call it the face in the mirror. Or again, if you're lucky enough to have audio and video in close proximity. And we do have a lot of hospitals that have started installing that so that they can closely monitor their patients. And then rule number 21, there's another rule out there, another federal law known as the Safe Medical Devices. So if they wrap that around their neck and they died, you also have to report it to the Safe Medical Devices Act. And if you're accredited by the Joint Commission, that would also be a reportable sentinel event that you would have to do a thorough and credible root cause analysis, and you would have to do it within 45 days. So I mentioned earlier the reporting, but the one thing I didn't tell you is if they die and all they have on is 1 or 2 soft wrist restraints, then what has to be in the log? So, and you have to complete the log within 7 days. So in the medical record, I would say the CMS restraint log was completed as required. And then in the log, it would say name, date of birth, date of death, attending, medical record number, and primary diagnosis. You don't have to send the log in, but if they request to see it, you have to do that. So in conclusion, you want to make sure that anyone who puts them on, takes them off, or monitors them is trained. We also want to make sure that our board is trained since they're responsible for everything that happens. Leadership should be aware of their responsibility. Policies should be revised to be consistent with these requirements. And again, you should be auditing it to make sure that you are doing it correctly. And this is for long-term care, but a lot of what we learned in long-term care in the hospital came from long-term care. So this is actually a restraint worksheet that I thought might be helpful if you just kind of as a tool for that. And then this is especially with the ligature risk, CMS amends tag number 144 and tag 701. And so, and I did this probably with a hospital that I worked with 15 years ago, where we created safe rooms. We had 2 safe rooms in the emergency department. We had 1 in the ICU because we used to have overdoses and suicidal patients. We had a safe room on the medical surgical unit in case they had behavioral health units and needed an IV. And this is a free book that you can get off the Facility Guideline Institute by David Stein. And it's on how to create a safe room. It has a self-assessment tool so that you can have a conversation. This says it's updated periodically. It was actually updated again last year, I think in April also. But if you go out to the website, it's there. So anyway, in fact, I'm currently working on an educational program on ligature risks, complying with the CMS and Joint Commission standards, and I go into a lot of detail about that free document from the Facility Guideline Institute. So anyway, that brings us down to the end. And again, if you have questions, CMS, I have given you the CMS email address that you can get it directly to CMS. And when I was the hospital legal counsel, that's exactly what I wanted to do. I wanted to get it in writing, and I wanted to, to do that accordingly. Also, I have given you my phone number, and I'm pulling up here. We had a couple of questions that were sent in before the program. So I'm going to go through those first. And meanwhile, you can be typing them in the chat line. In just a second, I'm going to turn it back to Isabel. But the first one was talking about, the first question we had was asking about PAs and if they can order it. And again, we've talked about that. In my state, they're a dependent practitioner and they're not permitted to do that, but that will change when CMS changes it from licensed independent practitioner to licensed practitioner. And then somebody sent me a picture of a specific MIT and asked if it was a restraint. And it's funny because I had actually sent that same picture to David Ettinger, the head of CMS, who said, well, based on this and looking at the manufacturers that calls it a restraint, that would be considered to be a restraint. And then the other question was, how often must staff be trained? Again, it says ongoing. Again, I didn't know what that meant either. I called David Ettinger, and he said we expect it to be every annual or on a yearly basis. So again, the recommendation is to do it in orientation and maybe consider it during your skills lab. So those were the questions that had been chatted in before that. And I'm going to see now if there are any chat questions. I don't see any, but I'm going to send it back to Isabel Estranda, our moderator, who can again tell you if you have a question, how you can ask it at this time. So Isabel, back to you. And also I want to thank Beth Hudson from Posey for asking me to do this, and they've both been great to work with. But Isabel, I'll send it back to you to tell our attendees how they can ask a question.
Thank you so much, Sue. What a great presentation. It's very informative and insightful. So we're very lucky to have you as part of our program this year. So throughout your presentation, the audience has been able to input questions in the chat panel. We've gathered some of those questions here now. So I'll go ahead and start with the first question that was submitted. So the question is, do you support the use of a restraint chair to be used on a psych unit not related to transport to court?
Well, I can tell you that I happened to find that restraint chair on the internet one time, and I thought it was mentioning that it could be used to transport a patient. I am aware that some units have tried to use that. I'm also aware of a state that was not happy that their hospitals were in fact trying to use that particular chair to transport a patient. So you always want to be familiar with, again, any state-specific regulations. But the most important thing is that however we're transporting a patient, whether that be on a cart, whether that be in a wheelchair, we need to maintain the safety of the patient. Thank you for that question. Isabel, before we go to the next question, I also noticed under handouts that you have the PowerPoints loaded here. They can also download them right off the right side of the screen. Is that correct?
Yes, that's correct. The handouts have been uploaded as a PDF file, and they're available for the audience to download at this moment, and it was available throughout the presentation. If you don't have a chance or didn't get around to downloading, we'll also include a download link with the survey that we send out later today. So it'll be available in a third platform to download the presentation. Okay, as for the second question that we have, it is there a time frame to correct missing notes in our restraint documentation?
Well, usually you have a policy, and if you forgot to admit something, and there's usually a policy on how you do that, or if somebody forgot to document the restraint sheet and they went home and you say, hey, you forgot, come in tomorrow, then most hospitals will say that you will document the date and time the care was given, note that it's a late entry, and then document the date and time of the documentation. Now, obviously, if you think you're being sued, you've got a complaint and summons, it's probably too late to go back and do any amendment. But if it's a short amount of time and there's a legitimate reason for doing that, then most hospital policies will indeed allow you to do that.
Okay, and I have another question here. It's a little long, so bear with me. If an emergency department patient was to present with an altered mental status and perhaps combative due to a mental condition, and the patient is held for a blood glucose check to determine underlying causes of the behavior, would this be considered a physical hold?
Well, basically what CMS says, and indeed one of the last questions, I can tell you that with the one about the chair, I can tell you what CMS says, and I can also tell you what they don't say. And the reason why I was so excited when they came out with this web address, or this email that you can email questions, is that you can get it directly to the horse's mouth. And so whoever asked me that question, if I were still at the hospital, and the same way you can go to, we were Joint Commission accredited, and you can go to jointcommission.org, I always would research everything, and I would hear it directly from CMS. So you could send that question in. So the bottom line is you have a patient that is, again, comes in the emergency department, and we believe that the patient is a diabetic and they have a history of diabetes and they're acting very unusual, and we need to get a blood sugar. And the question is, when can you hold that patient down? When is holding somebody? Because remember, we said if you're holding them for medical reasons, then it's not a restraint. If you're holding them because they're a behavioral health patient, it's a restraint. So in this scenario, you're holding them down. You have a behavioral health patient who you're holding down for a medical reason. And so I'm guessing that the CMS, again, we can ask CMS, email it to them and get a direct response. But in this case, it's because of the blood sugar. Now, if you want to hold that behavioral health patient down and give them forced medication, then that would be considered to be a hold. You would have to get the ED, which is not a big deal because we have the physician write the order in the ED because they're always there with us, and then we get the order, for the medication. But again, if it's medical reasons, again, CMS says that's different as opposed to holding somebody down because you're going to force, psychotropic meds because they're a behavioral health. So it sounds like in this case, the person was doing it for medical reasons, trying to get, blood sugar to determine if they're hypoglycemic. And I remember one time that we were taking care of this child, and her mother was just ballistic, and the child said, you guys need to check her blood sugar. This is not her behavior. And by golly, she had a sugar of like 25. I can't believe she was not passed out. So again, if it's for medical reasons, CMS says that that's an exception. So holding that child down for the LP, or holding that child down to give them the antibiotic because we think they're septic or whatever.
Thank you so much, Sue. Another question that we have, how do you determine the length of restraint monitoring time for a chemical restraint?
Well, part of it is looking at the PDR and determining what the half-life is. And again, this is something we would always ask our pharmacists because again, CMS just says that if it's again, they tell us what is a when a restraint when a drug is used as a restraint and the four things that can help us understand that, but they don't really talk about how long you should do that. So usually we look at, the half-life or how long that drug is going to be affecting them to determine how long we're going to do that assessment. And
Thank
of course,
you. And
sorry,
go ahead.
sense. If you have somebody in renal failure or liver failure and that drug is metabolized that way, then again, on the other hand, if you have someone that takes a lot of drugs and you're like, man, if I had an alcohol level that high, I'd be dead or whatever. Again, you do need to use common sense, but we do use the PDR and the drug book and the package insert to determine that.
Great. Thank you so much. Our next question. What training does a nurse need to be qualified to perform the 1 hour and subsequent face-to-face assessments for violent restraints or seclusion?
Okay, so I talked about this earlier. So in the hospital where I worked, there were three things whoever was going to do the 1 hour face-to-face. So the first thing we did is they got basically the program that you got today where we went through all 50 pages of restraint standards so they were aware of it. The second thing is they had to go through the training on what to document. Remember the 2 slides, and I said we had a form and we had a computer module that would walk them through how to document that information. And the third thing is we required them to have an 8-hour CPI or similar course. And again, we offered it once a month. We had the director of our behavioral health that offered it every month, because if you're going to send somebody into lion's den, we want to make sure that if they grab their hair, they can extricate themselves. We want to make sure that they know how to do a safe takedown. Again, we don't want the patient to be injured, nor do we want our staff to be injured. So those are the three things that we required. And we have seen some survey activity in this where hospitals have been cited because they haven't adequately made sure that those people doing the hour face-to-face are adequately trained.
Thank you so much, Sue. We have about 3 more questions here. So one of them is, if a patient is acting violent towards others due to a medical reason, such as alcohol withdrawal or hypoxia, do we follow the requirements for violent restraints?
Well, and the question that you ask is very good. And in the CMS manual, and I'm always surprised we don't get more questions on this, because I know that when they came out and we were applying them, that this is something that I thought, wow, I'm just surprised more people, don't have questions on it. But again, usually if you, and that was the scenario about, well, they're up and they're walking around and it's a full moon, or they're, should you restrain them? Generally, what CMS says, and this is what I have found to be the most helpful determinant of it, if that patient is admitted with a behavioral health diagnosis, they're schizophrenic, something like that, then that behavior is probably going to be violent and self-destructive. If that patient is admitted with a non-behavioral health diagnosis, and they get confused at midnight, it's a full moon tomorrow. My friend said, then I'm going to work tomorrow because of the full blue, super blue, red moon or blood moon or whatever. But say that they're working and this patient has Alzheimer's or some medical reason, then generally that is considered not to be violent self-destructive. Now, that's a good rule of thumb. You'll see that listed in the 50 pages of requirements, and it's always been a guide. And sometimes it's a matter of degree. I mean, if I walk in and this Alzheimer patient is throwing furniture, and I mean, it's just really, just trying to swing and bite and is really violent, then I might kick it up and say they're violent, self-destructive. But normally it's the diagnoses, if they're a behavioral health, that will help you determine that. But again, there is no clear test. There's no clear line. CMS attempts to give us three examples. in the COPs if you go back and read those. But again, it's never been that crystal clear. But again, that's pretty good guidance that can kind of help you out.
Thank you, Sue. Our next question. You have not mentioned involuntary physical escorts. We do document these as a restraint, even if only a minute or two long. Can you comment?
Well, so if you're walking somebody down a hallway and you're taking them to their room and they are not free to go right or left and they are being escorted, and again, CMS has no discussion of this, and that's why you didn't see it in the slides, because even though they have, and you're thinking, wow, that's 50 pages, I can't believe that, maybe they need to have more 50 pages. Of course, we don't really want any more requirements, but they don't discuss that. But generally, you have to read the definition of seclusion. And if you're physically prevented from leaving somewhere, like, again, it's not being on a locked unit. So if you're walking them down in a locked unit, that's not seclusion. But if you're walking someone down a hallway and they're not allowed to leave and they have to go where you go, then, does that meet the definition of seclusion? Again, are they in a locked unit, or are you preventing them from, leaving? So again, the reason why it wasn't in the slides is because CMS doesn't address that at all.
Thank you, Sue. And our last question for this presentation, should you report assault, staff injuries by a patient to the police?
Should you report assault? The patient assaulted you?
Assault or staff injuries by a patient to the police?
Well, this is a tough question, and the thing is that you should really have a policy and procedure on this. This is something that we usually do with risk management, and we also with legal counsel. Usually we write policies on that, and it's not uncommon to say, if anyone's been assaulted, that they can still file a police report. You still have to remember that under HIPAA, some things, now the fact that now, for example, under the substance use disorder new regulation that went into effect and the new changes that go into effect next month on February 2nd, they specifically mention in there that if a patient who has a substance use disorder that's admitted to a unit, they have to be told that if they assault somebody, that you can notify the police, you can tell them their name, address, what happened. And a lot of hospitals do permit now remember, it's worker comp, because if you're on the job and you're employed and you're injured, it's going to be a worker comp claim. But some hospitals have allowed the staff to go out and file assault charges, especially if they have been seriously injured. So again, you should look at your policy and talk to your administration, and especially in risk management, because we're seeing more hospitals that do allow that to occur, and hospitals that have taken or allowed staff to go after legal actions, again, if they've been seriously injured. Now, at a minimum, they need to fill out an incident report because of OSHA. And again, it could be considered to be, again, a worker comp injury, so they need to fill that out. And a lot of hospitals then take care of the worker who has been injured by something that happened. And just recently, I went to a whole hour program that, and I also mentioned that that's an OSHA requirement. OSHA says that you have to have a policy on workplace violence. And so a lot of hospitals have developed some and I've been to probably a total of maybe 7 programs to show how different hospitals are setting up programs for workplace violence. And OSHA will cite you under the general duty clause, and the OSHA penalties, we're talking about EMTALA has doubled and then had a cost of living, and fraud and abuse has doubled and cost of living, and OSHA, again, those penalties have all gone up. So they're on the radar screen. But OSHA, if you go to OSHA.gov, they have a special hospital section, a website now, and that and workplace injuries, musculoskeletal and back injuries are double the normal thing. And OSHA's going after hospitals under the general duty clause. So a lot of hospitals are looking at that, not just from the CMS part, but also from the OSHA perspective.
Well, thank you so much, Sue. This is very insightful and informative presentation. I know everyone is appreciative of your help guiding everyone through the CMS standards. This concludes today's presentation. If we did not get to your question, please feel free to email Sue directly. Her email is on the screen right now, and we'll go ahead and send the contact information for her as well when we send out the survey. So as a reminder, if you have joined the presentation with a group of your associates and only one person is registered, please email their first and last names and email address to iestrada@posey.com. Each person will receive a webinar survey where the option to receive the credit is available. You will receive the certificate a week after completing the survey. Sue, thank you so much for your time. We truly appreciate it. Thank you everyone for participating today, and goodbye.